Okay, good morning, ladies and gentlemen. Welcome to day 2. Welcome to what I think is going to be a very important and a very interesting panel discussion led by me. For those of you who haven't seen me before, at either this year's WISH or previous WISH conferences, I'm Stephen Sacker. I work for the BBC, for the Hard Talk interview show on the BBC. But it is my great pleasure and my privilege to be here today to chair this discussion. As I'm sure you know, as you've decided to come here and sit here, we are discussing tuberculosis today, and we're discussing this very important WISH report, which brings together ideas on, and I'm quoting here from the title of the report, innovative solutions for the elimination of tuberculosis amongst refugees and migrants. So there is a very particular focus within the TB sort of challenge on particularly vulnerable communities of refugees and migrants today. It is a very important focus. For me, I will admit, and I'm sure you've heard me say this before, I am not a man trained and steeped in medicine. I'm a layman, but even just doing the most cursory reading around TB, I was actually amazed still by the power and the prevalence of this disease, particularly in the more disadvantaged, the poorer parts of our world today. I think it's right to say that just a couple of years ago, when I saw the figures for 2022, there were 1.3 million deaths as a direct result of TB infection, which makes it the second most deadly infectious disease in 2022 after COVID-19, I believe. So this is a very, very real challenge, and we are focused on a very particularly vulnerable groups, communities of people within this whole question of how best to deal with the TB challenge. Let me introduce to you my panel. It's a panel of great expertise. What I would do or say, which is what I always say, is you're going to love meeting them all in terms of hearing their views, but don't give them each an individual round of applause, because that would make them overconfident at this stage of proceedings, but also it would be a bit time-consuming. So just give them a riotous, loud round of applause when I've introduced them all. How's that? So let me begin nearest to me by introducing you to Dr. Teresa Casaeva. Now, Dr. Teresa is director of the WHO's Global TB Program, and she also happens to be the chair of the report, the forum that produced this report this year. So Teresa is going to speak first and give us an overview of what's really important about this work, and then we'll develop the debate. Next to Teresa is Dr. Michela Martini, who is Senior Regional Migration Health Specialist at the International Organization for Migration. So welcome to you. Then we have Dr. Muna Al-Muslamani, who is Director of the Communicable Disease Center here in Qatar at HMC, the Hamad Medical Corporation. Then we have Biens Gavanas. Biens is going to forgive me. I can't pronounce her name exactly as I should, because it involves a very important click, which I am unable to reproduce. But anyway, it's wonderful to have you with us, Biens. She is Vice Chair of the Global Fund Board, and as I'm sure you all know, the Global Fund, in its commitment to combating the most dangerous infectious diseases, is absolutely focused on TB as one of the key challenges it must address. Then we have Dr. Paul Spiegel, who is Director of Johns Hopkins Center for Humanitarian Health, and he is a professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. That's a heck of a title. I hope I got that right, Paul. And then I'm delighted to say that next to Paul is Joseph Mwangi Macharia, who was born in Kenya, weren't you, Joseph? But you came to Qatar. You are here not least because you are a TB survivor, and we want to absolutely hear your account of what happened to you and weave that into the whole sort of debate about best ways to tackle TB, particularly amongst migrant communities. So, Joseph, we really thank you for being here. So there you go, ladies and gentlemen. There's our panel. Please give them a very warm round of applause. Now, Dr. Teresa, I'm going to start with you. I've been brandishing this report. You've spent an awful lot of time bringing it all together and getting it written, and many of us will now be reading it. But for today's purposes, it's really important that I give you a chance just to tell me and everybody here, what do you think the most important themes, the most important points are about the report, and why in particular you have drilled down so deep into this challenge of tackling TB amongst refugees and migrants?
Thank you very much, Stephen. Good morning. Good morning, distinguished audience. And it's a great opportunity for us to be here today and to put spotlight on the problem of tuberculosis in the context of migration and refugees. Stephen, you've made disclaimer that you are not expert, but I believe that by the end of this session, you will become passionate advocate for TB. Because TB, in fact, it's not only airborne, contagious, infectious disease, but it's also touchy. And we will share with you the story, try to dive not very deep, but share some substantial, important information. Indeed, we are very proud to be here today, and we would like to share our gratitude, a special thanks to Qatar Foundation, to the WISH Forum for this opportunity, for collaboration with us. And this is a result, this report is a result of the collaborative efforts of multiple partners, not WHO alone, by the way, WHO across all three levels, several departments, Department on Health and Migration, Global TB Program, plus very important partners, and our research partner Foundation Mero, our advisory group of partners, broad group, and of course all the key community representatives. So I can continue, but thank you for the panel. And we hope that exactly with the same passion and efforts, the problem should be addressed also globally. Tuberculosis, as you know, is one of the oldest global epidemics. Epidemic that doesn't recognize borders and nationalities. And unfortunately, the number of TB incidents, in other words, people falling ill everywhere, every year is increasing. Of course, it's concentrated in the highest burden countries, but important also to keep in mind that about a quarter of the world's population has been infected by mycobacteria, and it means that has some potential risk of development. It's affecting the poorest, first of all, the most marginalized, the most vulnerable groups. If we look at another big global challenge of migration, growing problem, it's also affect, first of all, the poorest and the most vulnerable, and it's not surprising to see that these two big problems matched at some point. And when two giants are matching, it's becoming really difficult to manage and requires some urgent actions. And with this message of urgency in our report, we are proposing very concrete 10 innovative solutions that should be implemented in every country with the joint efforts of all the partners, all the actors on TB field, and broader on the health and beyond health field, because it requires multi-sectoral efforts, as we can clearly see. We'll not go into the details, but these 10 points are very action-oriented. They're based on the NTB strategy, global NTB strategy. They're based on the latest targets and commitments of the UN General Assembly high-level meeting, and they require, first of all, bold political leadership, responsible and action-oriented, with sufficient investments, with addressing all the regulatory and other barriers, bureaucratic barriers, to provide access to all who need it, first of all, to the most vulnerable refugees, migrants, displaced people, to the TB services, because it's transmittable disease, treatment is long, still not easy, and sooner they will get access, better will be the outcomes and less will be the transmission. Of course, we expect that all these medical intervention will be high quality based on WHO latest recommendation and with uptake with the best diagnostic tools. Multi-sectoral, multi-stakeholder efforts are absolutely essential, and of course, everything what is measured is done. It requires robust system of monitoring, cross-border collaboration, and sharing information, and these are essential conditions that should be in place.
Great. Well, that is a great opening and gives us the context for all that we're going to discuss. I'm going to move it on as we go here, an opening thought from all of the panel members to you, Dr. Michaela. Now, you work for the International Organization for Migration. Your business is thinking about flows of people and how best to manage and make, you know, humanitarian sort of systems that work for people who are on the move. So I can see that here in our discussion about TB, there are real questions about how best to diagnose, to treat people who are often very poor, often are on the move, often outside the reach of national health systems. So you tell me what your job and your focus is when it comes to the TB challenge in terms of the Office for Migration.
Thank you so much for the question. It's very nice to share such a panel with distinguished colleagues. Thank you for coming to this panel. Yes, indeed. As International Organization for Migration, we have a dedicated health division, and TB has been always a cornerstone of our program. TB, as was said, is a disease of poverty, social vulnerability, marginalization, exclusion, health inequality as well. And migrants, they often found themselves in this situation. They cannot access services, especially if they are irregularly in the territory. They are fear to lose the job. If they are at the workplace because they take a sick leave, they don't have a health literacy for early diagnosis. For instance, if they have symptoms, they don't go as a priority to the health system. So think about when you move, the first priority, especially the first years, is what? Looking for a job, integrating the society, understanding health is the least to come. And this is one of the problems to expand the early diagnosis. So linked to this element, IOM, since the beginning, has been pioneering on the TB program. But something I want really to maybe send as a first message. We are talking about poverty, social marginalization. Those are the social determinants of tuberculosis. While I think tuberculosis in terms of clinical and management has been really done great progress. With early diagnosis, TB, we need to say, is it treatable? And we can manage. In terms of social determinant, we are still far to have a proper living condition, working situation, and this is one of the causes of TB growing, especially in the migrant population. So the first message in this regard, don't underestimate and continue the fight of improving living and working condition, especially within the regular pathway of migration. The now is getting important. And as IOM, the second reflection, I would say, is follow the people, not only the disease. Because some of the, it's estimated that 1/3 of undetected tuberculosis is among this population, migrants, refugees, displaced, vulnerable people, because they are hidden in the society. Sometimes they are hard to reach. So in the meantime, we are following the health indicator, incidence, prevalence of TB, we should not forget to follow the people and where they are and reaching the remote area, especially when you're dealing with mobile people. As a doctor, you need to know if the person is going to move for treatment, care, and continuity and follow-up. So you need to expand the cross-border coordination with the other countries, which is still missing. We have, for For instance, now Iraq is experimenting a growing trend of tuberculosis because of the movement of the Syrian, and now we have the movement from Lebanon as well, going to Iraq, etc. So cross-border movement is important. What do we do? That's very long. I try to be brief. As I said, it's one of the cornerstones of our program. I want to focus on some core important program. One is the health assessment. The health assessment is a program that helps people to move through regular pathway, and also for refugees to be resettled in the third countries. So we have a proper health screening, including tuberculosis. Through this program, IOM has developed a highly specialized expertise on TB detection for laboratory, specialized laboratory, but also for case management, including for MDR TB treatment. So we have more than 100 clinics worldwide. We have 2 teleradiology centers, one in Manila and one in Nairobi, connected with 130 laboratories worldwide for referral for X-ray report. And just to give you some number, last year, so we processes 1,300,000, let's say, people under this program, so immigrating to third countries, and we detect 1,500 TB cases. So incidence is not high in this group, but definitely the health assessment is an important pillar for public health surveillance, because of course we report the cases, we can do early diagnosis. So we are reinforcing this program also with capacity building to government to strengthen the capacity through the legal pathway.
And you find governments around the world are very receptive?
Definitely. Actually, this program, thank you for the question, is done under the request of the government of receiving countries. So we have large program with US, UK, Canada, all the countries. It's a very systematic program. We work in collaboration with CDC for the US, all the public health institute in each country. We work together for highly specialized. Our doctors are clinical doctor certified for this program. And this is a very large expertise that we can offer also in terms of capacity building. For instance, there was a moment in Kenya we were running an MDR clinic for the refugees with 120 patients. It was a huge number.
Right. Well, Michele, I'm going to stop you there. Thank you so much for that. So we've heard how one hugely important multilateral institution is really focused on combating TB amongst these vulnerable populations. So let's now switch from the multilateral to the national, and let's go to Qatar. And Dr. Muna, you are the director of the CDC at Hamad Medical Corporation. So tell me about Qatar's experience. I mean,
Sure.
Obviously it's a community, it's a nation state which has a very high proportion of incomers, of immigrants. And tell me how you deal with the potential challenge of TB within your population.
Sure. So good morning to everyone. It's my pleasure to be with the great panelists. First, I will discuss about TB national strategy. So TB national strategy, it's under the umbrella of Ministry of Public Health, and with the coordination and collaborations with the Hamad Medical Corporation as a communicable disease center, we are implementing the strategy. So part of the strategy, we are looking to the old population who are like vulnerable to the tuberculosis. So CDC mainly, it's a hospital. It includes National TB Reference Lab as well. So we are looking to our population especially from refugees and immigrants. So we have a good collaborations going to the refugees with the IOM. And they visited us several times with the CDC USA and United Nations and related to the refugees, because they need to be sure about what we are doing to our populations who had developed or suspected to have tuberculosis. Plus, good coordination and collaborations even with the Ministry of Interior and Ministry of Labor, because even for migrant, they need to look to their, about their living condition as well, and they need to maintain their confidentiality as well and human rights. So there is a key aspect of the cross-border collaborations in the TB care in the state of Qatar. We developed a pre-arrival screening, especially from the high-burden countries. So what we did, Qatar National TB Program has implemented screening procedures in collaborations with the medical commissions, which is under Ministry of Public Health. So medical commissions and under Ministry of Public Health or the Ministry of Interior, they communicated with the several offices in the high endemic countries. They need to do pre-screening before reaching Qatar.
What does screening involve exactly?
So chest X-ray quantiferon test. So we need to rule out they don't have active tuberculosis or even latent TB. Okay? And if they have signs and symptoms. So Qatar approach of the screening, especially for those migrants before entry to the country origin, and it's aligned with the WHO recommendation as well. Other approach that we have comprehensive referral pathway. So we need to see patients, as you mentioned, taking a full history and examination, and they need to be on board. Once they will come into the Qatar, within 1 week, we need to see the patients, not more than this. So they have fast access to the health care. Even we are receiving those patients directly from medical commission from the same day, we will see and assess the patients. And we need to say this is latent infections, TB infection, or this is suspected active tuberculosis. So we need to do all the follow-up and the procedure related to take the patients, and we will admit them on the same day as well. So regardless their gender, regardless their age and nationality, they are referred to the Communicable Disease Center, and we treated them with the zero cost, and we have very advanced technology related to the PCR genome sequencing and to identify multi-drug resistance as well. And we introduce as well, we have first-line treatment, second-line treatment, and based on the WHO for MDROs, protonamide and bedaquiline as well, despite it's very, very expensive medications, but we brought it for our populations, either even including migrant or refugees, they need to take this medication based on their, of course, diagnosis. Advanced technology, I said, we have multidisciplinary and holistic patients across all the system. So in our team in Communicable Disease Center, we have specialized nurses, specialized doctors in tuberculosis. We have, as you know, those type of patients, they will stay for a long time in isolation. So they need social support, they need mental support, so psychologists even on board with us, dietitian even with us, because TB can cause weight loss and they will become like undernourished. So we need even to calculate their medication based on their weight. We need to focus on their nutrition as well.
All of this is very expensive. Who pays for it?
It's government. It's a free of charge. It's government.
Free.
Yeah, it's government. It's a free of charge. Awareness campaign, because, TB as a TB, it's a stigma in the community. So we are going to the community to address and to remove this stigma. And, because they are a migrant, if they have signs or symptoms, maybe there will be underreporting. They will not seek the medical advice. So we need to go for them to teach them about the signs, symptoms. You need to report in case. There will be no deportations. Rather than early detection will be early treatment rather than late, treatment and with the complications of TB disease.
And sorry, it's interesting detail. You're saying from the very get-go, when you're talking to people, you're saying, look, we need early testing, we need screening, but we can absolutely guarantee there'll be no deportation.
No deportation, of course, no deportation, because you cannot deport people with active tuberculosis. Rather than you need to admit and to treat them and to clear them from TB. And then after that, after discharge from the hospital, we have a system in the place, follow up for them. And after they will finish the treatment, we will give them a certificate that they finished the treatment. And we need even to follow up after a while as well, because we need to resolve any reactivation of the disease, yes.
No, the detail is really interesting, and thank you for laying it out, Dr. Mona. Just one very simple question. You've obviously had this system in place for some time. It's an extremely intensive, detailed system. What impact has it had? What is happening to your trends in TB infection in Qatar, and are you winning the war against TB?
Yes, because this is our aim. That's to end or elimination tuberculosis. But don't forget, we have a lot, as you said initially, we had a lot of immigrants. So immigrants, they are moving across the border. Even if they will discover that they have tuberculosis, they will receive the treatment, but in the middle of the treatment, they need to move to their country. So once they will move to their country, as a government, we need, through IHR, which is International Health Regulation under Ministry of Public Health, we need to notify his country that he will move there with his medication because he needs a follow-up. It's not only just to receive, and the treatment should be under DOTS therapy, direct observed therapy.
Okay, well, Muna, thank you very much for that. So, oh, by the way, ladies and gentlemen, I should have said this at the very beginning, but I'm going to say it now. Already we're generating some really interesting information, different perspectives on this debate about how best to treat and deal with the TB challenge amongst vulnerable groups, particularly the migrants, the displaced people. I'm sure there's great expertise amongst you in the audience, and if you have a question for any member of the panel, go to the Wish app, go to the page which is devoted to this particular session, and you'll find an opportunity there to lodge a question, put a question in. And thanks to the miracles of technology, I've got my phone. I will receive all the questions. I've got a couple already. So do put your question in, and I promise I'll put it to the panel because we've still got a fair amount of time left. So definitely, please do that if you have a question. Jens, I'm going to come to you. We've just heard what is being done in, what is, let's face it, a very well-resourced country like Qatar. You work for the Global Fund. The Global Fund is absolutely committed to the global TB challenge. So while Qatar's story sounds very positive, they are doing an awful lot. How do you see the global picture when it comes to battling TB, trying to win this war against TB, and in particular with the most vulnerable communities?
Thank you very much to the Qatar Foundation and to Wish for hosting the summit and for inviting the Global Fund as a partner in the fight against TB, but also for shining a light on an issue that, as we have heard, has been with us for ages. And before I talk specifically about the Global Fund, allow me to say that we had been talking about neglected diseases, and we had focused a lot on other diseases. And the question that one asks yourself is, why has TB been around with us for so long? When I grew up as a child in apartheid Namibia, the disease that we identified with amongst our people were TB. And I'm glad that the report also points out it's the poor, it's the marginalized, and the vulnerable. But above all, it is those that do not have a voice and power. And that's why organizations such as the Global Fund has been established to fund interventions in the 3 areas of HIV, malaria, and tuberculosis. Now, a lot of people say TB is preventable and treatable. HIV, we know, can be prevented, it can be treated, but it's not curable. So we are still facing today people, about 1.20 million people died of TB in 2023 alone. So the question that one asks oneself is, are our interventions not working? Now, I always say that most of us work in countries that are at peace. And peace is not only the absence of war, isn't it? It's the absence of poverty, of disease. But let me just make the distinction between those that are in active conflict and those that are not in conflict, and how challenging it is for many countries to deal with the TB burden. What more for countries in conflict? What more for people that are crossing borders? And remember, we used to say long time ago, I don't know whether WHO still says it, the disease knows no borders. It knows no borders, and therefore collaboration, cross-border collaboration particularly is important. And the Global Fund has recognized that because it has worked with IOM to look at regional initiatives rather than just country-specific initiatives. And I can lay out what are the issues that, the kind of interventions or initiatives that we have taken. Technology is playing a very critical part in whatever we do. And innovative solutions, as was mentioned, is what the kind of instruments that we are using in the diagnosis and the treatment of TB. Now, I can go on a long list, but I'm sure we will get another round. Should I go on?
No.
Oh, please,
no,
can I go on? I'm joking.
I love listening to you, but you should stop for now, and we're going to come back to you, because I know I particularly want to ask you about Tanzania and what we can learn from Tanzania, but I'm not going to do that now. We're going to do that later. Paul, I want to bring you in and your analytical eye, because you're there at Johns Hopkins. I know you're looking at a lot of different approaches around the world to this problem, particularly when it comes to the movement of peoples, poor and disadvantaged communities, the difficulty of surveillance of these communities. And of course, surveillance is very important to a successful TB combat strategy. So tell me what you think works, what we can learn from different strategies around the world.
Sure, thank you very much. And just to say that I'll also bring in, so before Hopkins, I was with the UNHCR, the High Commissioner of Refugees, for about 15 years. And it's interesting to try to compare, for example, Qatar and what you've been doing and what's happening in Darfur right now, for example, and trying to address TB in a situation like that. So it's completely different. I think I would like to start first by stating clearly that we should not assume that people that are moving are carrying TB and infecting those that are not, number one. And so just like early on when we looked at HIV in these situations, we really need to look at the TB, the prevalence of TB at the origin, where they're going to, and then their trajectory, because they become much more vulnerable for a variety of reasons. And therefore, in each step, there are ways to reduce to protect people as they move forward. So
I mean, you've just made a very important point. Do you think there is a real risk of a sort of scare factor here if you focus too much on the degree to which these days TB is a disease of those who are displaced, those on the move, those whose communities have been disrupted? Yeah. You plant a fear in host communities, which can be very negative in terms of the way they then see these people who are coming in.
Absolutely. I mean, when I was at UNHCR, we would always say at least a double discrimination of being a refugee, you're discriminated against, and then everyone believing that you are transmitting the disease.
A health risk.
A health risk, yeah. And it's really not true in many situations, but we have to be honest, it is true in other situations. So in the report that talks about, in Europe, migrants that are coming from countries with higher prevalence of TB for the most part. So there is this risk. But in many other situations, and we saw it with HIV and we see it with TB, people may be moving within a country or outside of a country where the risks may be different. And in fact, they may be at more risk, the migrants may be at more risk of getting TB because they are living amongst populations with higher prevalence. So I guess the bottom line at the beginning is just to look at what the TB prevalence is and not make the assumption that people that are on the move are transmitting disease. But in terms of surveillance, then briefly, there are a lot of ways to move forward, but they continue to be very challenging. So one of them is trying to get to the people. And there have been some examples, community health workers from their own populations with whom they have trust can make a big difference. But a lot of this will depend on the legal environment and the policies. And so if people know that if they get tested for TB and they're an undocumented migrant and will potentially be thrown out of a country, it ain't gonna happen, and so it's gonna be pushed underground. The other area, because I don't have time to talk enough about everything at this point, would be what people have mentioned, cross-border. One of the biggest problems that we find is this lack of continuity of care, because people move from one place, they may be being treated with a different protocol, they come into another place with a different protocol, but they don't have their medical records. The good news and the bad news. The good news is that the technology is there now, and it's easy for people to have their own personal medical records. So they have their own agency, and they decide when they want to give this medical records and to whom, as opposed to medical records being kept with the healthcare facilities. Then it's very, very difficult, despite best efforts, to have a hospital or a primary healthcare center in one country and provide that information to another in many of these settings. So there are these PMRs or personal medical records where now, much of the information can be in the...
Would that apply in some of the poorest communities, in some of the states where governance is difficult, to say the least?
For the most part, yes. I mean, even in the, I was just back from Mali 3 weeks ago, and a lot of problems there. But yeah, it is possible now. More and more people, because you don't need to have a smartphone, you can have even just the old Nokia phones.
Right.
So it is possible. The problem still remains, though, and maybe others will talk about this, is the trust of these people who are often being discriminated against in their own countries and where they're going to have the trust to be able to say, okay, even with biometrics, I have the trust to be able to provide someone with my protocol, with my treatment, and will that person then report me to the authorities, and I have to go elsewhere. And finally, to say the other big issue is we saw this coming over into Europe and through Greece and Italy, is people often want to go to many other places, so they don't want their medical records in country one, because then they think they may have to stay there.
Yeah, well, that's a great introduction from you, Paul. Thank you very much. It would be very wrong to have a panel about TB, and particularly relating it to issues connected with migration and displacement, without actually hearing from somebody who's been through the TB experience themselves. So Joseph, we're very grateful for you joining us. I know you're obviously resident in Qatar. I think your home country originally was Kenya, right? Yes. Tell us a little bit about your experience with this disease, and maybe we can then figure out what we can learn from it.
Good morning, everyone. My experience with TB from when I got diagnosed.
Joseph, do hold the mic as close to your mouth as possible.
My experience with TB from when I got diagnosed, first it was terrifying. Fear crept in. Having studied TB back in school and knowing the conditions that it presents itself with, it was terrifying. But when I got to CDC Qatar, the nurses there took time.
Forgive me, Joseph, I'm sorry to interrupt, but how did you get ill? I mean, what happened? You got very ill before you went to any doctor, or what happened?
No, basically what happened is I was in one of the routine clinics when I felt ill, I had a cough, and when I went for the clinic, that's when, after they did the tests, that's when I was diagnosed with TB.
Right.
Yeah, from there, that's when I was referred to CDC. And once I got there, the nurses really took their time to explain to me and to let me know what I'm about to go through. What stood out mostly was the personal-centered care, or the personal-centered approach, whereby each doctor or each and every nurse took their time to introduce themselves to me. They took me through the treatment procedures. I was involved actually in the decision-making, which was really unique, and it helped me feel like I am connected to the person who is attending to me, and I am connected to the decisions that are being made. Also, I had access to the medical records through the My Health portal, where I could access all the records of the treatment, and all the medicines that were administered to me. I had all the knowledge on I would say I had all the knowledge and the possible maybe allergies or anything. Everything was explained to me in detail.
How long did your treatment last?
It went for a whole year. Yeah. First phase was 6 months, then went for the second phase was another 6 months.
Right.
Yeah.
And what happened to your employment?
No, my employment was not affected. Everything was continuing smoothly. Yeah. And also, even after being discharged from the hospital, there is this wonderful program where the medication is, where there's a follow-up through the video-assisted dots, that's the VDOTs, whereby whenever you take the medicines, you record a video and there's an assigned nurse who is following up on your daily intake or uptake of the medicines. And also there's one amazing feature whereby whenever you'd require the medicines to be restocked, the medicines will be delivered right to my residence whenever the restock will be needed,
Right.
which was a very great feature.
That's all, I mean, I'm sure that's all music to your ears, Dr. Munna, because we heard your sort of vision for how treatment works in Qatar, and Joseph, your experience seems to bear it out. Just tell me about, if you think about the community you have in Qatar, and I'm just guessing, but I'm sure you know lots of people who've come to Qatar from other countries. Do you think in terms of education and awareness, there is an understanding that, if TB is in a community, that the state has incredibly sort of rigorous systems to diagnose, to treat, to support, and that it's free, and that there's no issue about deportation being raised? Do you think that communities in this country are well educated about that?
Thank you for your question. Sure, there is a lot of outreach programs to the workers, whereby I'm actually involved in that as part of the Patient Family Advisory Council at CDC, where there is a lot of programs. There is videos running in the malls explaining about the TB and the TB treatment. Also, there is camps that are done mostly where the workers are staying, where there is free medical camps, where there is testing, and there is all this training and awareness on the TB.
Yeah, thank you, Joseph. Okay, it's time for a couple of questions from the audience, and I'm going to remind you to keep asking the questions on the app, because I'm going to put them to our panel. I want this to be an interactive session. The first one we got was for you, Dr. Munna. It's, can you tell from the statistics how successful you've been in reducing the rate of incidence of TB in Qatar since you rolled out this program that we've heard about this morning?
So it's data-driven. We hire epidemiologists for us as a communicable disease center, and we have CDC considered like a central hub for all tuberculosis across the state of Qatar. Every single patient diagnosed with the tuberculosis, we will be registered him, and we need to follow up him. So all the data will be shared at the end of the year to the WHO, so we uploaded the site. It's the data-driven, it's very important for us to see the trend. I mean the incidence and the prevalence of the disease in the country, and based on this, we need to have our own actions and the plan. We will look to the mortality, patient's outcome, mortality. We will see how many cases from MDROs we have from the registry that we have. So based on the registry and the data, we're going to have our own action annually, and we are feeding the WHO as well.
Yeah, I mean, Teresa here has just got a very useful graphic which shows the graph. I mean, your numbers, incidents of TB were going up until, Teresa, is it about 2020 when the spike?
2020.
And now you're gradually going down. So obviously you're hoping that you can get that right down.
Yeah, but we have a challenge. We have a challenge with them, especially with the transit populations. I don't like to say transit population, but once migrants, they will know that they are affecting with the tuberculosis, we will start to give them treatment 1, 2 months, 3 months. At the middle of the treatment, they need to go back to their home. And based on the definition of the WHO, that's mean left the country, it will be count against us that lost the follow-up. So that's why sometimes the census and the data do not become accurate, despite we inform the receiving country or the original country that he's a travel, and this is his diagnosis, and this is the treatment. So what we did, we came to agreement with the patients. We need to convince him to stay to finish his treatment, because if he will go, maybe he will lose his treatment as well. In addition, we are trying to let him to be or her to connect with us through video dots. So this is what we are trying to do.
Okay, thank you. Biens, there's one here for you. How has the COVID-19 pandemic affected TB services for migrant and refugee populations? And what lessons do you believe have been learned from the COVID pandemic? No, it's actually, this one was specifically for Biens, but go on.
Thank you. There is no doubt that COVID has really impacted the progress that had been made, not only in terms of diseases, but also look at the health worker situation. But I'm also glad to say that the Global Fund, as a response to COVID, identified specific funds that we call the COVID-19 mechanism, which was funds that were set aside to deal specifically with COVID and its impacts, because you must remember that there was a lot of confusion as to the symptoms of COVID and TB. And so there were maybe misdiagnoses in the process, but because of the investment through that mechanism, we could really halt and make progress in terms of continuing the success that we had with COVID. With COVID, but also in dealing with the TB. If we did not have that mechanism, I'm sure we would have had significant problems. And when doctor was speaking, and I looked at the time of the downward and the upward, it was exactly during the time that COVID hit.
Right.
And I'm sure that it was the same throughout.
Yeah.
Yeah.
Teresa, did you want to say something on that?
Yes, this is a very important question, and I would like also to clarify. Since the very beginning of COVID-19 pandemic, WHO, based on its modeling, alerted that there could be significant lasting impact on TB if services will be disrupted. And unfortunately, all our predictions came true. And we've seen, due to COVID impact, more than 700,000 excess additional deaths from TB due to COVID. And we can see continued increase also as a result of COVID-19 impact of TB incidents. They're continuing increasing according to our last global TB report. And this could be predicted if services would not be disrupted. This is one of the main lessons learned, and we should care not only about, of course, COVID was the biggest and unprecedented pandemic, but we've lost also lives from other diseases, because systems in many cases were not prepared enough. But in terms of some similarities between two diseases, indeed, they're both affecting lungs, and there have been some similar symptoms, but some countries, again, following WHO advice, they managed to establish dual testing, and Global Fund also supported through the C19RM initiative, and it clearly showed that you can benefit from the strong TB programs with multiple benefits, addressing other lung health issues. And we are happy to see that that Qatar managed to build a robust system. And using this opportunity, I would like to refer to the Global TB Report app version. You can download and see data from 194 countries across the globe, and to understand what are trends in your country.
That's very useful. Thank Thank you for that. Michele, did you want to come in as well?
Yes, it's getting very interesting conversation. As IOM, you know, we have a cross-cutting partnership with all of them, and this conversation is really embedded on our work. I want to add something on the progress, and especially on the Global Fund impact, because as IOM we are we are leading a regional global fund here in Middle East. It's the Middle East response with Libya, Jordan, Iraq, Yemen, now Lebanon. Did I say Lebanon also? And we are expanding now in Libya for the TB detention center. And this program started in 2017 just to bridge the gap of the national global fund that they were not capturing the issue of human mobility and migrants. So it started with this principle, but in the years, the Global Fund approach was really effective to support the HIV and the TB program in all the countries. And one of the successful stories, I think we need to see the Lebanon and Jordan, they just recently launched the roadmap toward the elimination. So we were able to reinforce, strengthen the laboratory services, decentralize the services, and the transport specimens. So Global Fund, it's really one, I think, the most effective, especially for the cross-border so far. And something we need also to think about this cross-border element. It was mentioned by Dr. Maha, sure. And when we are dealing with migration, the cross-border is not captured at the national level. The health system is still static, is still based on the assumption that patients, they approach the health services in that point and they come back. Now it's totally reversed. We have seen the number. I mean, we have reached the highest number of migrants just in Middle East. 10% of the population, so equal to more or less 40 million of people in Middle East, is either refugees or migrants. And something important, they go in the neighboring countries, they stay in the region, the majority. Only 20% of it goes to Europe. So we need to start changing the narrative that everybody is going to Europe, and especially for the TB, sometimes I feel like the attention is given again to high-income countries with the disease infection control. Yes, that's an old story. It's an old story when, State Island in the US, we are talking, and we have Dr. Spielberg is pioneering to change the narrative that when we are talking, it's not only prevention of disease control, but the overall system when people is moving. Again, social determinant of health, the cross-border, the vulnerability, and the poverty. Another reflection, and thank you so much, very inspiring panel, is also the fact that we really acknowledge that Qatar is making amazing progress. The difficulties from our experience is also when we work in more fragile states and with the fragile health systems. So health coverage and the systems outreach, all the mechanisms, it has a cost. Sometimes countries, they cannot afford. This is why the intervention of the Global Fund is extremely critical and the development partner. But through this experience, we have shown that also in countries with fragile systems, we can make an impact. We focus on resources and great engagement of the ministries of health as implemented.
No, you make a great point, and obviously Qatar has the resources to run this great program. But actually, just a very crude question for you, Jens. Just in terms of the Global Fund's prioritization of the 3 diseases that you really aim to combat, HIV/AIDS, TB, and malaria, what percentage of your overall sort of budget do you devote to TB?
I will not remember the exact figures, but obviously HIV gets almost 40, 50%. Then it's malaria and then TB. Pardon? 35 yes, percent.
Right. Roughly a third, is that right?
Yes.
Yeah, okay. All right. Well, thank you for that. As I predicted, some really interesting questions are coming in. I'm going to just take a few. I mean, there's been a lot of, in terms of your recommendations, there's a lot of focus on cross-border cooperation, on better data storage and sharing, on better surveillance systems. I get all of that. One thing we haven't discussed at all, and again, this is me, the layman, not the medical expert, but it's an interesting question. Somebody's asked, how much does the BCG vaccine help with this story of attempting to eliminate TB? And within that discussion about the BCG vaccine, is there any potential for mass adult vaccination to combat TB?
Yes, I can.
Yeah.
Let the medical expert answer.
Yes, I can try to respond, but just to clarify, from 3 diseases, Global Fund is dedicating 18.6% to TB.
Oh, so not a third?
Not.
No.
And it's the biggest fund, the global international fund, the Global Fund, but the shortage of funding for TB response is critical. Only 26% is available globally in general, with a lot of contribution, of course, from the international donor funding sources. It's absolutely insufficient. Right. Now, in terms of vaccine, BCG vaccine is more than 100 years old. Mm. And unfortunately, it's not effective. It's protecting only young children, newborn, up maximum to 5 years old. Right. And of course, the most of the burden is, as we can see from the report and from other sources, among young adults.
So it would be totally ineffective amongst adults?
Ineffective,
right.
Ineffective. But we have some good news. We have some good news with new vaccines in our pipeline. We have around 16 vaccine candidates, 6 in the phase 3 clinical trials, and recently WHO for activation this work launched Global Vaccine Accelerator Council, and we expect now, according to the task given to the global community, to have up to 2028, 2029 new effective vaccines, and we're very optimistic. There are at least 2 candidates, very promising, and hopefully this vaccine will be available. But again, learning lessons from the COVID-19 and other vaccination campaigns, we should be prepared. There should be access, first of all, in the highest burden countries, in low-income countries available, and that's why we're learning these lessons and preparing ground.
But and rolling out these potential vaccines then will involve a massive commitment, global
It would become a game changer, absolutely.
Panelists, are you all very optimistic about the outlook for, longer-term outlook for vaccines?
Yeah. Yes, but what we see consistently is that when they're rolled out, they'll go to the national populations first, then perhaps refugees, undocumented migrants, maybe less so, it depends. And then we haven't really talked about the situation that we work in a lot in these non-government controlled areas.
Right.
So I'm listening to the panel, and I'm also, although I'm a Canadian, I'm living in America right now, and I'm pessimistic about certain aspects. The vaccines, yes, very optimistic, but money has come up and funding has come up. And I think there's a high likelihood that funding will be decreasing overall in global health, as we have been talking about, number one. We haven't really talked about MDR, the multi-drug resistant TB, which is incredibly expensive. And in many of the countries that I work in, there isn't enough money for MDR TB for their own nationals. And so I remember being in Kenya a couple of years ago, and it was big discussion about, can we provide treatment for MDR TB to non-Kenyans, and who will pay for it? And then the other aspect I would say is the other concern is the legal components, or the legal policies that make sure that non-nationals, migrants, and I'm less concerned, I think we're all less concerned about migrants that have the legal possibility to work in a country. It's those that don't have, often what we call the undocumented migrants, those internally displaced persons that are suppressed by governments. Are they going to be able to, are there legal policies there to make sure that they can access? And then finally is this issue of funding. It's not just getting free health care. Many of these people can't afford transportation to get to these areas.
Right.
There's the follow-up, there's the providing sufficient food. So there are still tremendous challenges ahead of us, despite positive or some optimism to be seen.
Yeah. Wow, the questions are really flowing in, so let's get through a few as quick as we can. Just stick your hand up if you want to take on the question, and I will get you involved. Let's do this one. Beyond immediate diagnosis and treatment, what are the long-term health implications of TB that host countries need to address in order to support successful long-term integration of migrants and refugees, presumably those who have been through the TB experience? What are the long-term issues? Joseph, will you say, yeah? Let's hear from Joseph first.
Would you come again on your question?
Well, the question is really, you get your treatment when you've got TB, but is that the end of the story, or does it leave you needing certain sort of longer-term care or other longer-term issues that the society you're living in needs to be aware of?
Basically, I would say, beyond the treatment, there's no any other long-term issue that seems to be of concern basically to me. I believe once the proper care has been done, it can be quite effective.
And right now, you're completely over it. You're fit and well and healthy.
Yes, I'm TB free and I'm very fit.
Yeah, good.
May I just add something there,
Yes.
if I may? Macharia, you are very fortunate that you came to a country like Qatar. Many countries still discriminate. There is still a lot of stigma attached. And if I can avoid being tested, I will avoid being tested, because I know what being tested means in certain surroundings. So I couldn't help but bring in the human rights lens in the discussions that we have, because sometimes we forget that we're actually talking about people, and that people that are not dying, but people that are living, and that have overcome the fight against TB. What is their continuous role in societies, and especially societies in which they have moved into, which cultures they don't understand, the language that they don't speak? How are they accepted in those communities, apart from the fact that you have a disease that carries stigma and discrimination? So I think sometimes the figures don't say everything.
Right.
It does not tell you the person behind the figure.
No, I think that's a powerful point. I mean, Joseph, just to stick with you for a second, somebody wants to know, and I'm glad they want to know, how is Joseph inspiring more people in Kenya through his story to mitigate the impacts of the stigma of TB? And can you, Joseph, have any influence at all in the health system in Kenya, learning from the CDC experience you've had in Qatar? I mean, I don't know whether you go back to Kenya or whether you've talked to people in Kenya about your experience here. Tell me.
Yes, I go back to Kenya every now and then. I would say out of the experience I've had in Qatar, and basically it's a great experience. I devoted myself to give back to the community here in Qatar by being an advocate of the patient.
Right.
And by being an agent of change, whereby mostly in CDC, we raise the issues that affect the patients, or what could make the life of the patient during the span that they are in the hospital, what could make their life a bit easier or a bit better. And there is a lot of events and a lot of involvement. And thanks to the able leadership of Dr. Mona, that most of the patients in CDC didn't have a great time. There is therapeutic arts, there is access to there is lots of session that continues in CDC. And through that, or through what I have run, I can be able to impact the same to my community, since I have the first-hand experience. And it's, given the chance, I can really do it.
Yeah.
Yeah, thank you.
Yeah, go on, Michele, yeah.
Yes, I have a question for you from the migration perspective, because the people who are moving in the countries, they go through pre-medical health assessment. As you said, this is what IOM also we are doing with screening. So the person arrive health in the countries. Some of the countries, they do TB screening again, etc. And their experience is also that they arrive healthy, and the condition of the working and living condition make them compromise the health status, not only for TB, on other elements. And the focus is also for the IOM, is the working condition that sometimes are conducive, and the housing standards. So the question for you, and yes, you are lucky to end up in Qatar, definitely. And how and when did you know about the diagnosis? I assume you arrived healthy, so was somehow the conducive environment that exposed you to the TB, and was you a contact tracing for another TB cases? How you identify? And yes, from the migration perspective, because one of the lobby that we are also doing in the Gulf countries is to expand occupational health, to have monitoring the data. They may have it, but the condition, working condition, they are not yet optimal, especially those are areas highly affected by climate change. Majority of the migrants, they work outdoor, and they have a high impact, not only respiratory tract infection, not traditional kidney disease, etc., because of the exposure of climate change. Qatar, actually, from this perspective, has done a lot of progress, and you also release very useful guideline for housing of migrant workers. So that the question, how did you know about your diagnosis?
How I knew about my diagnosis about TB. Basically, it was, as I said earlier, it was just during the regular clinic when I went to the workers' health center. That's when the diagnosis, the test was done, and I was found to be positive of TB. For the contact tracing, the working environment was very good for me. The accommodation was very good for me. So I believe it's something that maybe I picked just along the way. And I can't say that there was any okay, just what I would say is the environment was conducive. I could not say that it was the TB came due to congestion or anything, or due to any working-related environment. Yeah.
Okay, well, let's because we're about 10 minutes left. I want to squeeze in as many questions as possible. What role do behavioral insights and culturally sensitive communications play in designing really effective TB awareness and educational campaigns that truly will resonate with refugee and migrant communities? Who would?
Of course, everyone can respond, and I'm sure the colleague from CDC will be happy also to comment. But I would like, first of all, to support Kenya a little bit. It's one of the high TB burden country with 100 times higher burden than in Qatar, but they are managing quite well. They reduced 40% their TB incidence and mortality since 2015.
Right.
They're trying also to do their best. And in terms of cultural sensitivities, awareness sharing is absolutely critical for timely diagnosis, for sharing message that TB is, in vast majority cases, preventable, treatable, and curable disease. only the key condition is timely and accurate diagnosis and treatment, because another risk is of interruption of treatment or misdiagnosis is that more severe forms of TB, multi-drug resistant forms can develop that are much more difficult to treat and with poorer treatment outcomes. So this sometimes information should be shared on local languages in the format which is clear and understandable, not so medicalized. Maybe we are today also somehow a little bit medicalized, but this information is absolutely critical, and we see some very good examples. By the way, you can learn from the report. There are some best practices with the concrete solutions that could be uptaken.
Can I add? Yeah, so we have a continuous community engagement and related to the communicable, it's not specific tuberculosis, in addition to the all communicable diseases. But again, we are going to talk to the people with the lay languages, with the different languages. It's like their languages. It's not medical languages, and different, like Hindi, Urdu, Kenya. So that's why Joseph, he's very important one for us. He's member on advisory patients and family group in CDC. So even they are giving us like a feedback from the community, what's their need.
Yeah, no, Dr. McKillop, I know you want to get in, but I'm very keen to get, because we've got so many questions now, I just want to get as many in as we can before we finish. What are the particular challenges of TB prevention and control in densely populated refugee camps or temporary shelters? Who would like to take that on?
Everyone can respond. So the crowding living conditions, this is unfortunately the situation which support more active transmission, because it's transmittable disease, and so it can affect quite quickly people who are in close contact with you. That's why in these specific groups, regular screening and use of the latest tools for screening, we have now mobile X-ray, computer-assisted diagnostics, chest X-ray, all these could be used. And of course, a rapid molecular test, this is absolutely critical. But we should avoid any additional stigmatization of this population. Migrants and refugees are not a threat themselves. They are becoming more vulnerable, and it requires urgent support. This message should be clear, and even if we look at the countries with a high refugee and then migrations rate and review over the several years, there is no increase of TB incidence in local populations. There is no increase, but essential condition is timely access to diagnostics and treatment services for all migrants and refugees.
I can add to this maybe a concrete example in Iraq, in the camps. And we were conducting community event-based surveillance. This is something is not yet well practiced in the Middle East. I have seen it, but in Africa, community event-based surveillance is extremely powerful tool. And in Iraq, actually, conducting event-based for other outbreaks, other communicable disease, we identify tuberculosis. Sometimes that's why I wanted to intervene in the community level. It's extremely powerful to intervene in the community because we can enrich the unreachable. But we need to build the trust with the community. And sometimes going with the tuberculosis because of stigma problems, not the right angles. So integrated approach. And this is why we are promoting also on IOM, TB, in integrated action in the community level. We are now working, and this is piloting, the approach with our colleague working on livelihood in the community. So different topics, not health related, but we start introducing health promotion and building the trust to access services, because sometimes the common element is this one. So this is an experience, and in Iraq, this community event-based surveillance was very powerful to detect, especially the community that knows who has recently arrived, and they know if they have symptoms. So building the community trust is extremely important.
Paul, quickly, because then I've got one last question.
Yeah, just very quickly, is that, so most refugees and migrants do not live in camps. They live outside of camps. And it's actually easier to address, even though camps are crowded and there may be more transition, it's much easier to find them, to do screening. The challenges are often when the migrants and refugees are spread out in cities and interspersed, and it's very hard to be able to get to them. It's much more of a challenging from a surveillance perspective.
Yeah, that's a good point. Okay, one last question, which is a really important one, and it sort of looks forward, which is important to do at the end of a conversation like this. The questioner asks, can we expect sort of international, meaningful international legal frameworks that ensure equitable access to TB healthcare services for undocumented migrants, asylum seekers, and refugees that guarantee to remove the risk of deportation and discrimination? I mean, that sounds idealistic. Is it possible to imagine that sort of collective global approach?
If we don't imagine a better world, I don't think we can be anywhere. I think we should continue to hope that we will get to a point where, as I said earlier, discrimination is not solving the problem. It's driving the problem under the carpet. And we know what had happened in our fight against HIV. If we did not go out in the way that we had and fought stigma and discrimination, many people would not have gone for testing. Many people would not have gone for treatment. So I still come back to the issue of anyone that does. I'm not saying people should necessarily disregard the laws of the land and cross, but we know we are talking about people that are fleeing. They are fleeing their own countries because of conflict or because of disasters. Now, if you get to the other side of the border and flee into another country, obviously we would like to have human laws and human treatment for people that come into your country under those circumstances. And I can tell you, I was a refugee myself. I fled my country and lived in refugee camps in Angola and in Zambia. If Zambia and Angola had closed their borders, I would never have been who I am today. So I definitely, as a former refugee myself, I know what I'm talking about.
No, you definitely do. Actually, I'm going to leave the last word with you, Teresa. In the light of what Jens has just said, and I'm thinking of what Paul said earlier about the current geopolitical climate and the current funding climate, I think it's fair to say that both are not necessarily very positive right now for global health initiatives and for a collective effort on challenges like the global TB challenge. Are you, hand on heart, somewhat pessimistic about the next phase of the fight against TB or not?
I've never been pessimistic. And in that case, I should leave my job. But I truly believe, and it's in my heart, that we can and we should do better for TB. It's could be very good, successful stories, how through the united forces we can address the needs of millions of people with a centuries-old disease. And we have the best opportunity today. We should stop using excuses and other competing priorities, climate change, other pandemics. There will be conflicts. Unfortunately, the world is not becoming any better. And we should live today and address today's needs of people. And there are no reasons that they should die from preventable and curable disease. It's imperative to provide access to treatment. We have better options, and it could be done. And there are a lot of unnecessary expenditures in the world that are even killing people. Let's save lives, and let's be all together advocates for this. So I believe in the power of people's united voices, and I believe that we will come to ending TB soon.
Can I just, as the Global Fund, since you talked about money,
Yeah.
and we are about money to save lives, just say, just before I came to this session, I was listening to a discussion on Gaza, and something that left me wondering was, at the time that we have an increase in conflicts and an increase in the diseases, because it's going back there, we have a decrease in funding. And I think it is important that one looks at it, because when we are talking about conflict situations, the breaking down of health systems, people have no access to whatever treatment. So we can make treatments available and medicines available, but if they are not accessible and if they are not affordable, then we are back to square one. So what I'm saying is, we are definitely finding ourselves in a situation where many organizations are going into replenishment, are going to demand more funding for the challenges that they are dealing with, including the Global Fund and many organizations. But I also want to say that we need to look at additional resources. We need to still continue to talk about domestic resource mobilization. Qatar is an example, and that's where you also talk about ownership over the lives of your people, but that you're also reaching out to other countries and assisting other countries. And Global Fund is really happy with the collaboration that we have with countries like Qatar, especially when we are dealing with humanitarian situations, and the same with the other partners. Global Fund is a partnership, multi-stakeholder, and I want to assure you, Macharia, that the communities that serve on the board of the Global Fund has got a voice and are representing those that are affected and impacted by the disease. Because in the final analysis, we need to listen to the voices of those that matter. Thank you.
No, well, thank you, Jens. And I think everybody will have enjoyed listening to this panel debate, because you've provided great insights, and I thank you all for joining us. Ladies and gentlemen, it's time for a break. I think the next session in here isn't for half an hour or so. So before you go and have a coffee or whatever, just please give a very big thank you to our panel. Thank you, panelists.